Good morning to you all. Today's topic is on prognosis and treatment plan. Coming to the learning outcomes, explain prognosis, explain the various factors to be considered in the determination of overall and individual tooth prognosis of a patient with gingivitis or periodontitis, discuss the rationale of etiotropic phase, and the last one is the construct a treatment plan for a patient with gingivitis and periodontitis. So, what is prognosis? Prognosis is a prediction of the probable course, duration, and outcome of a disease based on a general knowledge of the pathogenesis of the disease and the presence of risk factors for the disease. So, the prognosis will come after the diagnosis and it is made before the treatment plan. But the determination of prognosis is a dynamic process, that is, it should be evaluated after completion of all phases of therapy, including periodontal maintenance. Okay, so it is the prediction of probable course, duration, and outcome of a disease. So next one is that it is based on the how it is made. So it is based on the specific information about the disease and the manner in which it can be treated. It is also influenced by the clinician's previous experience with treatment outcomes. So that is depending upon that it leads to success or failure of the treatment. Okay. Then prognostic factors versus risk factors. And usually this prognosis is often confused with the term risk. So we already discussed about the risk factors and the risk assessment in the last class, and how it can be differentiated with the prognostic factors. Okay. So prognostic factors are characteristics that predict the outcome of the disease once the disease is present. Got it? And risk factors are categories that put an individual at increased risk for developing a disease. So that comes before developing a disease. Risk factors comes before developing a disease, and prognostic factors which will come after the uh, after the disease is present. Okay, so then in some cases it can be same, that is risk factors and prognostic factors are the same. For example, patients with diabetes or patients who smoke are more at risk for acquiring periodontal disease, and once they have it they will have a worse prognosis. So during this diabetes and smoking cases, there is which increases the risk of developing a disease, and also the prognosis will be worse in these cases. So coming to the grading of prognosis, so we need to grade the prognosis uh, to excellent, good, fair, poor, questionable, and hopeless. And so we can classify according to various factors. That is, prognosis classification schemes based on evaluating tooth mortality. It's being divided into excellent prognosis, good prognosis, fair prognosis, poor prognosis, and questionable prognosis. So we will go into the details of each. First one is excellent prognosis. In excellent prognosis, there will be no bone loss, excellent gingival condition, good patient cooperation, no systemic or environmental factors. So that it determines excellent prognosis. Whereas good prognosis, there is the control of etiological factors and adequate periodontal support ensure the tooth will be easy to maintain by the patient and the clinician. So there is good prognosis. So there will be disease condition, but there can this all the factors which lead to the disease can be controlled. Okay, so that is good prognosis. The next one is fair prognosis. Fair prognosis is that approximately 25% attachment loss or grade 1 furcation invasion, adequate remaining bone support, some tooth mobility, and presence of limited environmental or systemic factors. So that location of depth allow proper maintenance. So this the disease can, even though it is of disease condition, it can be maintained or it can be treated well with good patient compliance. So which gives fair prognosis. Whereas poor prognosis, there is 50% attachment loss and with grade 2 furcation invasion, that is grade 2 means the one wall will be fully be lost and with the intact of the other wall, and moderate to advanced bone loss will be there, and severe tooth mobility, and the presence of systemic or environmental factors. Location and depth of the disease condition will make maintenance possible, but it will be difficult, not like as smooth as the other case that what we explained before. Okay, there is poor prognosis, and then comes to the questionable prognosis, that if it is there is greater than 50% of attachment loss is present, with poor crown to root ratio, poor root form, class 2 furcations, that is with the location and depth makes access difficult, that is with root proximities or the root trunk distance, so which makes it difficult, the maintenance will be difficult, or class 3 furcation involvement is there, and if it is greater than grade 2 mobility and the root proximity with the presence of systemic or environmental factors, which leads to questionable prognosis. And the last one is the hopeless prognosis, that inadequate attachment to maintain health. There is less than one third of the bone is left, and advanced bone loss, that is what it is, advanced bone loss present, non-maintainable areas, and extraction is indicated. So presence of uncontrolled systemic or environmental factors. So it is lead to hopeless prognosis. So good, fair, and hopeless prognosis in this classification system can be established with a reasonable degree of accuracy. However, this poor and questionable prognosis depend on a large number of factors. So this is how it's been classified into different prognosis level on various factors. So coming to the prognosis based on the probability, the other one it was based on tooth mortality. This classification is based on the probability of obtaining stability of the periodontal supporting apparatus. So it is determining or it's evaluating. It's based on the stability, how we can achieve the stability even after the treatment. That is what it is leading to. There is favorable prognosis. The first one is that comprehensive periodontal treatment and maintenance will stabilize the status of the tooth, and future loss of periodontal support is unlikely. So this periodontal maintenance can be this treatment and the maintenance will lead to the stability of the tooth. That is what it determines. It is favorable prognosis. So especially this scheme is made based on the probability of disease progression as related local and systemic factors. So next coming to the questionable prognosis. Questionable prognosis, that is local or systemic factors influencing the periodontal status of the tooth, may or may not be controllable. If controlled, this can be stabilized, but if not, then future periodontal breakdown may occur. So that is a questionable one. Okay, and next coming to the unfavorable prognosis, there is local or systemic factors influencing the periodontal state cannot be controlled, so that the comprehensive periodontal treatment and maintenance are unlikely to prevent the future periodontal breakdown. There is unfavorable prognosis. We are expecting unfavorable prognosis, and last one is the hopeless prognosis, that is the tooth must be extracted. So this periodontal stability is assessed on a regular basis by using various clinical measures. It may be more useful in making treatment decisions and prognostic predictions than in trying to determine the likelihood that the tooth will be lost. So this always lead to professional prognosis, and then after the point of time or during the treatment plan, we can change uh, to the confirmatory prognosis or a definitive prognosis. So it is advisable to establish a provisional prognosis until phase 1 therapy is completed and evaluated. Okay. So after that, we can come to the definitive prognosis. So the revaluation phase is very important. So it is in the treatment sequence. It allows the clinician to examine the tissue response to scaling, oral hygiene, and root planing, as well as the to the possible use of chemotherapeutic agents were indicated. So the patient's compliance with the proposed treatment plan also will be determined. So it will lead to the definitive prognosis. So then coming to the various types of prognosis, there is diagnostic prognosis, therapeutic prognosis, prosthetic prognosis, and provisional prognosis. These are the various types. As we said before, we already told about the provisional prognosis. So these are the various types of prognosis. First one is diagnostic prognosis. There is an evaluation of the course of the disease without treatment. Without treatment, with the diagnosis, we are coming to a prognosis, that is diagnostic prognosis. There is what is the status of the teeth now and what is the anticipated future of this teeth. So we will be just seeing the diagnosis and coming to the prognosis. Next one is therapeutic prognosis. This is like given the state of the art and science of the periodontics and the knowledge and skill of the practitioner. So with the skill, so with the treatment which is going to have, and what effect will this treatment will be on the disease. So according to the treatment, it is leading to a prognosis that is called therapeutic prognosis. Okay, based on the treatment, what effect it is going to have on the course of the disease, that is therapeutic prognosis. Okay. And next is coming to the prosthetic prognosis, that is given the anticipated results of periodontal treatment and the periodontal health status obtained for the patient. What is the forecast for the success of the prosthetic restoration? Will the prosthetic be therapeutic or detrimental? So we are giving the result. Sorry, we are giving the periodontal treatment and periodontal health status and what the treatment we are going to give and what is the prognosis of that. So with the processes, for example, if we are giving a prosthetic restoration, will the processes be therapeutic or detrimental? Will it be going to be effective? That is what prosthetic prognosis. Then coming to the professional prognosis, that it will allow the clinician to initiate the treatment. So it's so coming to the provisional prognosis, this is starting up. That is before the phase one therapy, and we are starting with one prognosis, and this will allow the clinician to initiate the treatment of the teeth and have a doubtful outlook in the hope that a favorable response may tip the balance and allow teeth to be retained. So again, it will be evaluated after the phase one therapy. So these are different types of prognosis. You just need to know that what is the different levels of prognosis and in what aspect we are going to give different types of prognosis. So coming to the division of prognosis, there is prognosis can be divided into overall prognosis and the individual prognosis. So overall prognosis is concerned with the dentition has evolved. So there are various factors that influence the overall prognosis. And then coming to the individual tooth prognosis, there is it determined after the overall prognosis and is affected by it. Okay, so there is the overall prognosis and individual prognosis. So we are coming to the details. Overall prognosis includes the factors which include there is patient age, disease severity, systemic factors like smoking, the presence of biofilm, calculus and other local factors, patient complaints and prosthetic possibilities. These all are included under which all determines overall prognosis, whereas under individual prognosis many of the factors listed under local factors and prosthetic factors and restorative factors have a direct effect on the prognosis of individual teeth in addition to any overall systemic or environmental factors that may be present. So that is what we are telling, that individual tooth prognosis is determined after the overall prognosis and is affected by it. For example, in a patient with poor overall prognosis, the dentist would not attempt to retain a tooth that has a questionable prognosis because of local conditions. Okay, so that is, it will be always affected by individual prognosis, will be always affected by the overall prognosis. So coming to the factors to consider when determining a prognosis, it is overall clinical factors, patient age, severity, plaque control, patient compliance, systemic and environmental factors, smoking, systemic disease or condition, genetic factors and stress, local factors under that plaque and calculus, subgingival restorations, anatomic factors, short tapered roots, cervical enamel projections, enamel pearls, bifurcation ridges, root concavities, developmental grooves, root proximity, furcation involvement, tooth mobility, prosthetic and restorative factors under their abutment selection, and caries, non-vital teeth and root resorption. So the details will be discussed in the class, face-to-face class. Okay. So coming to the prognosis of specific periodontal disease, that is prognosis for patients with gingival diseases. There is gingivitis associated with dental plaque only. So there is gingivitis that is caused due to biofilm. So this gingivitis associated with biofilm, the prognosis will be very favorable since this factors, since the etiological factors can be eliminated, can be controlled. So this will lead to good prognosis. Okay. So next coming to the that is the plaque induced gingival disease modified by systemic factors. So this is related more with the systemic factors also. So there is an additional modification by the systemic factors. So the long-term prognosis for these patients depends on not only on the control of biofilm but also on the control or correction of the systemic factors. Then coming to the plaque-induced gingival diseases modified by medications. There is usually this medications that is the like drugs like phenytoin, cyclosporin, and nifuripine. So these all are related with the gingival enlargement. So this complicates the gingival disease. So this with the alternation of the drug and eliminating the source of inflammation. So this can lead to better prognosis. So the long-term prognosis depends on whether the etiology of the inflammation can be completely eliminated or the patient's systemic problem can be treated with an alternative medication that does not have gingival enlargement as a side effect. So coming to the gingival diseases modified by malnutrition. So when we discuss about malnutrition, especially by the severity of vitamin C deficiency, so this the prognosis in this patient mainly depend on the severity and duration of the deficiency and on the likelihood of reversing the deficiency through dietary supplementation. Okay, and then coming to non-plaque induced gingival lesion. So it directs with the course of that bacterial, fungal, or viral infections. So the prognosis depends on elimination of the source of the infectious agent. So finally, these allergic, toxic, or any foreign body reactions, as well as mechanical thermal trauma, if it can be controlled, all these lesions, if it can be controlled, then it will lead to better prognosis. So it mainly depends on the elimination of the causative agent. Okay. So coming to the prognosis of patients with periodontitis. So first it is coming about the chronic periodontitis. As you know, chronic periodontitis, it is a slowly progressing disease with well-known environmental factors. It can be localized or generalized. So this in this case it will be very slow as it is very slowly progressing. The attachment loss and the bone loss are not advanced. In some cases, if it is not advanced, that means slight to moderate periodontitis, definitely the prognosis will be favorable. So provided that the inflammation can be controlled through oral hygiene and the removal of local biofilm retentive factors. So whereas in patients with more severe disease, for example, if there is furcation involvement and tooth mobility, along with non-patient like patient non-compliance with oral hygiene practices, then it will be the prognosis will be questionable or unfavorable. Okay. So then coming to the aggressive periodontitis, as you know, that is aggressive type of nature with rapid attachment loss and bond destruction, and there will be a familial aggregation, and there is more prevalence of aggregative bacteria actinomycetin comitants. So these patients will have, definitely they will have phagocyte abnormalities and hyperresponsiveness of monocytes to LPS. So these all will create an unfavorable prognosis definitely. But with localized aggressive periodontitis, usually occurs around the age of puberty, and the patient often exhibits a serum antibody response to infective agents, which contribute to the localization of lesions. Even though it is like that, also like when if it is diagnosed early, these cases can be treated conservatively with oral hygiene instruction and systemic antibiotic therapy. But with more advanced cases like generalized aggressive periodontitis, there is if the lesions are treated with debridement, local antibiotics and regenerative therapy, the prognosis can be favorable. So that is secondly, if the contributing factors are there, if there is any cigarette smoking or other systemic factors, they are also influencing the disease condition. Then there can be cases like that does not respond to well to conventional therapy. So in these cases, it can have a questionable or unfavorable prognosis. Okay. Then coming to the periodontitis as a manifestation of systemic diseases like, for example, hematological disorders or genetic disorders. So, although the primary etiological factor is bacterial plaque, all these systemic diseases can alter the ability of the host to respond to the microbial challenge. So then it's mainly depends upon the severity of the disease, how it can be controlled. If there is any early detection, then if there is any like early intervention interventions, then the prognosis can be favorable. Otherwise, the prognosis in these cases will be questionable or unfavorable. And also to like more to add, genetic disorders also are also there. So this can also can have effect on the development of periodontitis. Okay, so there will be questionable or unfavorable prognosis can be expected all these cases. Then coming to the necrotizing periodontal disease, that is NUG or NUP, that is necrotizing ulcerative gingivitis or necrotizing ulcerative periodontitis. So in NUG, the primary predisposing factor is bacterial plaque, and this disease is usually complicated by the presence of secondary factors such as acute psychological stress, tobacco smoking, or poor nutrition. So therefore, superimposition of these factors on previous gingivitis will always lead to a painful necrotic lesions of type of NAC. So with the control of all these factors and the secondary factors, this prognosis can be favorable. Okay, so can be favorable, but the however the tissue destruction in these cases is not reversible. Okay, and the poor control of the secondary factors make these patients susceptible to the recurrence of the disease. So with the repeated episodes of the NUG, it can make this prognosis very worsen and may worsen to questionable. Okay. So the clinical presentation of this NUP will be similar to NUG, except that the necrosis extends from gingiva into the periodontal ligament and alveolar bone, and the progression may have resulted from multiple episodes of NUG or the necrotizing disease. So in these patients, prognosis depends on alleviating the biofilm and the secondary factors associated with NUG. So many patients presenting with NAP are immunocompromised by systemic conditions such as HIV. So in these patients, prognosis depends only on reducing the local and secondary factors. Not only on these local and secondary factors, but also with the systemic problem also. Okay, hope you understood like various diseases and their prognosis. Coming to the determination and reassessment of prognosis. So, all time the determination of prognosis of a tooth requires a careful and thorough assessment of the presence of disease. So, that is important. So, prognosis is based on accurate diagnosis. Always, this accurate diagnosis means makes accurate prognosis. So the treatment decisions will be made based on the prognosis, and the treatment decisions are made to improve prognosis. So first we will be making the provisional prognosis, and after phase one therapy, again we will be reevaluating, and so the treatment always should aim at improving the prognosis, not to satisfy the provisional prognosis. So the diagnosis and prognosis will change the treatment. So that is about determination and reassessment of prognosis. Uh, so when we come to the key to success, so if it is given in a pyramid shape, the base will be with evaluation, and this makes the diagnosis. And this diagnosis, the proper diagnosis will make a prognosis, and a better prognosis will lead to a better treatment planning. So that is the key to success. So coming to the treatment plan. So after the diagnosis and prognosis have been established, the treatment is planned. The plan should encompass immediate, intermediate, and long-term goals. So there is the immediate goals are the elimination of all infectious and inflammatory processes that cause periodontal and other problems that may hinder the patient's general health. Coming to the intermediate goals are the reconstruction of a healthy dentition that not only fulfills all functional and aesthetic requirements but lasts many years. Then coming to the long-term goal, this is what we always aiming at. That is the maintenance of health through prevention and professional supporting therapy. So there is a long-term goal. So what is the treatment plan? So if we want to tell about the definition, the treatment plan is the blueprint for case management. It includes all procedures required for the establishment and maintenance of oral health, so which involves decisions regarding the following. There is emergency treatment, removal of non-functional and diseased teeth, and possibly strategic extraction of healthy teeth to facilitate the prosthetic reconstruction of the patient. Treatment of periodontal diseases, it can be either surgical or non-surgical or resective or regenerative therapy. It can be endodontic therapy. It can be necessary or intentional in an intentional caries removal and placement of temporary and final restorations, occlusal adjustment and orthodontic therapy, replacement of missing teeth with removal or fixed processes or dental implants, and aesthetic demands and the sequence of therapy. So the decisions, treatment decisions are made with diagnosis and prognosis of the individual teeth and the overall dentition in mind. Okay. So treatment decisions, as we said, there is always made with diagnosis and prognosis of the individual teeth. And prognosis is usually established based on the diagnosis, whereas treatment decisions are made based on the prognosis to improve the prognosis. As such, diagnosis and prognosis will change with treatment. Okay, so coming to the flow chart, that is the data collection that will lead to the diagnosis, and after diagnosis it will be leading into initial therapy, and after that there will be re-evaluation after 2 weeks, and this will be leading to the surgery or retreatment of scaling and root planing, and then it is coming to the supportive periodontal therapy, that is the maintenance phase. So coming to the details of phases of periodontal therapy, there is emergency phase. Under emergency phase, treatment of emergencies like dental or periapical, periodontal or other. So any abscesses has to be treated first, and there is a preliminary phase, emergency phase. There is, it can be pain or abscess. Okay, that abscess, it can be due to periapical or periodontal. Extraction of hopeless teeth and provisional replacement if needed. So there is, it can be maybe postponed to a more convenient time. For example, during periodontal surgery, this extraction can be done. Okay, so there is a preliminary phase. Coming to the etiotrophic phase, that is we are more dealing with. It is very important. There is a non-surgical phase or phase one therapy. So which includes plaque control and patient education. There is diet control in patients with rampant caries and removal of calculus and root planing, correction of restorative and prosthetic irritational factors. It is, these factors will be hindering the oral hygiene maintenance, so it has to be corrected at this point. So this excavation of caries and restoration, there is temporary or final depending upon the whether a definitive prognosis for the tooth has been determined and the location of caries, it has to be given. And coming to the antimicrobial therapy, like with local or a systemic uh, therapy should be given. And occlusal therapy, there is a occlusal reduction, there is a trauma from occlusion has to be relieved if is that is one of the etiological factor for causing disease. And then minor orthodontic movement also included in non-surgical phase, and provisional spending and processes also under the non-surgical phase. So then coming to the re-evaluation, there is evaluation of response to non-surgical phase, that is rechecking pocket depth and gingival inflammation. There is all the factors, all the etiotrophic factors should be re-evaluated during this re-evaluation period. There is pocket depth, gingival inflammation, plaque and calculus, caries, everything. So after that, surgical phase. Surgical phase, there is a phase 2 therapy. that is which includes all the periodontal surgeries, including like regenerative receptive therapy or the placement of implants or endodontic therapy. Everything comes in surgical phase. Then coming to the restorative phase, that is phase 3, that is final restorations, um, the permanent restorations, fixed and removable prosthodontic appliances, evaluation of response to restorative procedures, and periodontal examination. Then coming to maintenance phase, there is phase 4 therapy, periodontal rechecking. That is under maintenance phase. This so every time we will be periodically checking for the deposits and all the gingival condition, occlusion, tooth mobility, and other pathological condition. So coming to the periodontal treatment sequence, so we have already discussed all the factors. So coming to the details of each, there is periodontal evaluation. So what all things to be noted that under each, that is patient education, which includes clinical findings, disease status, disease pathogenesis and prevention, personalized oral hygiene instructions, reduction of systemic and environmental risk factors, that is physician consultation, smoking cessation, periodontal treatment plan, under that oral hygiene assessment and education, non-surgical therapy, periodontal evaluation, and periodontal supportive maintenance. So under non-surgical therapy, as we discussed, there is all the non-surgical therapies. Uh, and also there is a subgingival scaling and root planing and extraction of opulous teeth if it is not done in the emergency phase, and reduction of all local systemic factors, okay, has to be done in non-surgical therapy. Then, as we said, periodontal reevaluation, which includes all the inquiry concerns of the problems of changes in patients' medical and oral health status, oral hygiene assessment and education, comprehensive periodontal examination, assessment of outcome of non-surgical therapy, determination of required additional non-surgical and adjunctive therapy. So coming to the surgical therapy, there is all root canal therapies, periodontal surgeries, periodontal plastic surgeries, pre-prosthetic surgeries, all will be included under surgical therapy. So under maintenance, so same like reevaluation, there is inquiry of new concerns or problems, inquiry of changes in patient's medical and oral health status, professional maintenance care like supragingival and subgingival biofilm and calculus removal, selective scaling and root planing, assessment of recall, interval, and plan for next visit. So this is the periodontal treatment decision tree. So there is so from where we are starting, there is a periodontal evaluation. So if there is attachment loss, that means it has to go to the, that means it determines the periodontitis. So which leads to periodontal maintenance. So it should be controlled. So if it is controlled, then only the maintenance. If it is not controlled, again scaling, root planing, and it has to be reevaluated. And after evaluation, it has to go through, if it is coming up with the same condition, it has to go through surgical therapy. Okay, if there is unresolved pockets, if it is excellent hygiene, disease resolved, then periodontal maintenance. If it is poor oral hygiene, it is not indicated for a surgical therapy, it has to go for again non-surgical therapy and then reevaluation. Okay. So when there is no attachment loss, that is only gingivitis. So what happens? So it goes to localized inflammation or generalized inflammation. If it is localized inflammation, just there is the prophylaxis, mm, and the other one is just the so if it is generalized, then it has to go for a scaling and then reevaluation. So if it is disease resolved, then only prophylaxis, oral hygiene prophylaxis need to be done. So overall treatment plan is based on the diagnosis, prognosis, disease severity, and risk factors. So this is the preferred sequence of therapy. This is very important. That is, this is a usually asked question. So which is the preferred sequence of therapy? So we have discussed all the phases of treatment. What are the treatments under each phases? So then coming to the preferred sequence, there is the emergency phase, then leading to non-surgical phase, then maintenance phase. Under maintenance phase, it can be surgical phase or restorative phase. Okay. So there is a sample treatment timeline that is following non-surgical therapy. If patient is placed on periodontal maintenance at regular intervals, surgical and restorative treatments are scheduled between the periodontal recalls. So there is a periodontal evaluation and the non-surgical periodontal therapy. So after that, caries control and again coming to the periodontal evaluation. And if there is persistent pocket and inflammation, it can lead to surgical therapy. And after surgical therapy, it is coming to the reevaluation, and then if it is resolved, then coming to the maintenance phase. So if it is not maintained, then is again surgical therapy, and then it is coming to the restorative dentistry. And if it is, then it is again coming under reevaluation, and then under evaluation, so it is coming at regular intervals, recall and follow up. So that's all about the treatment plan and the prognosis. So we will be discussing more in the face to face class. So thank you.